Hi everyone. I wanted to start this debate by presenting some of the pros I have found for the use of physical restraint and seclusion. There are many settings where one could use physical restraint and seclusion, but for this debate, I'm going to be talking mostly about students who have autism in a clinical setting or a school setting. So the first thing I want to talk about, my first point, which is like paramount for my whole argument, is that we use restraint and seclusion to be safe. The reason we use physical restraint and seclusion is to control the behavior of a student in an emergency situation. So I really want to highlight that. Restraint and seclusion should be used in an emergency. We shouldn't just pull this out of our back pocket when a student is escalating just to calm them down when we know we have other options to use. As behavior analysts, we have so many interventions at our fingertips, and we know how to provide positive behavioral supports in order to decrease negative behavior. However, there are certain situations where students have lost control and they will harm themselves or they will harm a caretaker, another student, or the like. So, I really just wanted to highlight that we should only be using restraint and seclusion in emergency situations, unless otherwise specified by a BCBA who is trained in using restraint and seclusion as an intervention. But for the most part, if we are using restraint and seclusion, it should be by a certified professional, someone who is comfortable implementing a restraint and who is doing it to ensure the safety of the client or other students or caretaker staff, whatever. I also wanted to talk about the fact that we sometimes use physical restraint to prevent property damage as well. And this is situational, but for example, if a student gets into a computer lab and starts destroying hundreds of thousands of dollars of computers, it would be appropriate to restrain that student from preventing the loss of all of those computers. Physical restraint can prevent possible damage to clients, to their caretakers, to staff, and can be used in those situations to reduce that risk. So, I also wanted to talk about another point that physical restraint can be used as a behavior reduction intervention. We can modify physical restraint and seclusion into an aggression contingent intervention for students. And basically what that means is that there have been a couple studies showing that once a student aggresses, immediately is restrained, and they've shown that through data that the behavior was reduced. And in most cases reduced to absolutely none. So physical restraint can be modified into an intervention plan, but should only be done by someone who is operating within their knowledge base, by a BCBA who has been trained on physical restraints and seclusions and knows how to implement them in an intervention plan. And lastly, I just wanted to talk about our ethical code. Ethical Code 2.0, Behavior Analyst Responsibility to Clients, is what I'm really going to highlight. The first one is that we have a responsibility to operate in the best interest of our clients. So we should always be thinking about what is best for my client. What can I do better for my client? Is restraint and seclusion the best possible option in this certain situation for this certain client? And also, we have a responsibility to keep our clients safe. Our clients come to us for help. Our sole purpose in our workspace is to aid in the success of our students or our clients. And keeping them safe is like the number one priority. So if using a physical restraint seclusion will not keep them safe, we should not use it. And in the same sense, if using physical restraint and using seclusion is the only way to keep them safe in that moment, we should absolutely use it. I truly believe that. I think, again, restraint and seclusion should only be used in emergency situations where there are no other options to keep them safe. But I do believe that there is a place for physical restraint and seclusion in the clinical setting. So, thanks.